Now, let's move on to the last topic of today, that is trauma to the duodenum and pancreas. It is by Dr. Niladri, MCH in trauma from AIIMS, and right now he is an associate prof in AIIMS, Jodhpur. His areas of interest are in trauma outcome protocols. Over to you, Dr. Niladri.
Okay, I'll be very quick because of lack of time. So, greetings from AIMS Jodhpur. The last topic for today is trauma to pancreas and duodenum, and I'll be discussing the anatomy, little bit of anatomy. Mechanisms, I think I'll skip because it's already discussed by Dr. Joses. Some basic investigations also, this part is covered, so I'll skip on to the management part mainly. So, a little bit of the duodenum and the pancreas lie. They are retroperitoneal, and just behind the liver, behind the colon, it's a very major area having a lot of major vessels. You can see the the SMV, the SMA, and the splenic vein going just below the splenic artery, going just over the upper border. The pancreas is usually divided into the head, the neck, the body, and the tail. And the neck region is basically the one which is lying just above the superior mesenteric vein. So this is arbitrarily how we divide it, and the duodenum is the C loop actually, which lies on the lateral side of the head of the pancreas, supplied by the superior and inferior pancreaduodenal arteries. So this is actually a complex. It's not a single organ. There are a little bit of complex injuries which we are getting, but isolated pancreatic injuries also we can get, but usually presents together. Even in isolation, it may present, especially in penetrating, but blunt, there may be a multiple injuries, like both through duodenum and the pancreas. Mechanism, the significant mechanism is the handlebar injury, as somebody had suggested, my previous speakers. The handle hitting the abdominal cavity and the things getting compressed between the handlebar and the lumbar vertebra, and that is where the neck of the pancreas lies. That is where the D3 lies. These two get injured very easily, along with a chance fracture to the lower thoracic and lumbar vertebra. Seatbelt injuries, spine injuries also associated. And the proper history about the mechanism is very important. It will guide us to thinking that yes, this might be the injuries. From outside, it may look very trivial, just a small bruise, but inside it may be a major pancreatic injuries. So just on the basis of the external features, we cannot comment on the severity of the injuries. Many of the patient might be stable, many might be unstable. So we get all types of situations in pancreas and duodenum. There are some certain clue points. Suppose in a stable patient, otherwise you are seeing that everything is okay, but there is increasing abdominal pain, increasing tenderness, persistent emesis or inability to tolerate oral diet, unexplained hypotension, nothing coming on the fast, leukocytosis happening, amylase levels going up, some proximal small bowel obstruction after trauma, or some abdominal sepsis in which you are not getting any hollow viscous injury. All these things might give you some clue towards a duodenal or a pancreatic injury. So we have to just keep our eyes and ears open. As I said, fast may not be reliable because these are retroperitoneal organs. A CT is by far the best modality, a CECT. It might tell you about some periduodenal fluid or air suggesting a duodenal injury, peripancreatic fluid suggesting a pancreatic injury, or vice versa. Even a periduodenal fluid may be present in case of a pancreatic injury. There might be some collection around the pancreas, a little bit of fluid collection from the duct. Now, again, MRCP, not usually recommended for routine practice, but yes, in case of pancreatic injury, this is probably the only place in trauma where we might need an urgent MRCP if we have a doubt regarding the pancreatic ductal injuries, because that is what defines the treatment. Pancreatic ductal injury is the defining factor. And if we cannot detect it on a CT, or is it not obvious, the transaction is not obvious, you think that there might be a ductal injury, so obviously you should do a MRCP if the patient is stable. And likewise, the management is likely to change. Little bit on the pancreatic injury first. So the AST has defined this grades of pancreatic injury. 1 and 2 being disruption of some portion or a major portion of the circumference of the pancreas, but the duct is not involved. Grade 3 is the one which we are concerned about, and obviously 4 and 5 are major disruptions. So grade 3 and above, the management shifts towards an operative one. One and two go towards a non-operative. If we go into the algorithm, we assess it by a CT. If we find a normal pancreas and some peripancreatic edema, we do a non-operative management, especially the grade 1 and 2 ones. We find a pancreatic laceration, moderate peripancreatic fluid, not sure about the duct injury, get an MRCP. No duct injury, non-operative. Yes, duct injury, laparotomy. And obviously, if there's a pancreatic transaction and extensive fluid, we need to do a distal pancreatectomy most probably for a grade 3 or grade 4 injury. The WTA, Western Trauma Association, is the same thing in details. Basically, for these expectant non-operative management, these patients may go into a pseudocyst formation or a pancreatic fistula, which will be considered later on. But in a major duct disruption in grade 5 or 3 to 4, we might do a damage control with drainage if it is unstable patient. If it is a stable patient, we might do a distal pancreatectomy. Now, distal pancreatectomy is usually done for grade 3 injuries in which the injury is to the left of the SMV. For a right side injury, we can either put a drain and come out. We can do a pancreatoduodenectomy, Roux-en-Y pancreaticojejunostomy, or we can just resect the whole of the pancreas. But mind you, you will be leaving with only a small part. So again, a lot of studies regarding grade 1 and 2. People are, I do not want to do a non-operative, but yes, non-operative management of low-grade BPDI is safe, and only 10 of all the non-operative patients required some sort of surgery. So very well managed non-operatively. Gunshot injuries are very old study. Earlier they used to do debridement and suture repair, treatment with debridement, grade 4 going a pancreaticotomy. But I don't think in today's world we need to do too much. If there is a small injury, maybe we don't go in. And if you're doing a laparotomy, just put a drain and come out if it's a very low grade injury like 1 and 2. Isolated duodenal injury. Now, this again has a asked grading into 1, 2, 3, 4, and 5. 1 and 2 being a laceration, small hematoma. We just put a NJ tube and a FJ, give TPN, keep some NPO if it's a small one. If it is a larger hematoma, we might need to do a clot evacuation by incising the serosa, taking out the clots and suturing it back. For a laceration, small laceration, especially on the antimesenteric side, a primary repair is good enough. We might put a patch, something like a prepyloric perforation or something like that. Or we can use the falciform ligament to reinforce the repair. A lot of repair methods have been suggested. A RAFI, in which we just suture close the abdomen in a longitudinal or and transverse manner. Like if the laceration is longitudinal, we close it transversely. And the tube duodenostomy, if we are doing it for an extensive repair, we'll put a tube duodenostomy, or we can put a retrograde tube duodenostomy with an FJ. Going to a serosal and mucosal patch, if it's a larger defects, especially in a D3, we use the jejunum to just put the serosa of the jejunum and attach it, and it will act as a margin so that leak does not happen. We can also use jejunal mucosal or pedicle graft, although I have never used this. Serosal patch is the one which is easier to do, especially in D2 or especially in D3 injuries. If we are resecting it, we can do end-to-end anastomosis. Again, I don't have personal experience in it. I would rather do a serosal patch repair or something like a Roux-en-Y, closing this stump and then diverting it with a Roux-en-Y gastrojejunostomy. Larger lacerations, people have done second duodenal resection and Roux-en-Y duodenojejunostomy, and third part and fourth part, even side to side duodenojejunostomy. Coming to the grade 3, in which 50 to 100% of D1, D3, D4 is involved, or 50 to 75% of the D2 is involved. Again, going for a reconstruction. So till grade 3, 4, like grade 3, we will go for some sort of reconstruction. It may be Roux-en-Y, it may be primary, it may be end-to-end, whatever. In case of grade 4 and 5, now we are thinking of a resection, pancreaticoduodenectomy. Usually, if the ampulla is not intact, we would think of a pancreaticoduodenectomy. Otherwise, we would try to do somewhat some sort of a reconstruction, especially with a Roux-en-Y duodenectomy, or closing that end and doing a duodenojejunostomy, I mean a gastrojejunostomy. All these things we can do. It's basically reconstruction versus resection. In a damage control situation, everything is bleeding. You just pack it, you resect the part, do not anastomose, go in later on and do the anastomosis. That can be done. It is very difficult to do a Whipple's procedure. If the patient is bleeding too much, it takes a little bit of time, and it's better done in two stage setting, doing the reconstruction later on. But these are reserved for a very high grade duodenal lacerations. The principles of management will be the same as we do for everything. Just one or 2 points there, that hemodynamic stability needs to be restored, intestinal continuity needs to be restored, decompress the duodenal lumen, use a lot of decompression in the stomach, the duodenum, everything should be decompressed. Provide external drainage because you are thinking of a leak all the time, and provide nutritional support. Complex combined duodenal pancreatic injury, these are also very common because these two organs lie very close together. We can, if the patient is stable enough, we can just resect that part and do a GJ along with a truncal vagotomy and duodenal closure, drainage of the CBD if that is injured, also, and external drainage. But we usually settle for a triple ostomy approach in which we decompress the stomach, decompress the duodenum by a retrograde duodenostomy, and put an FJ. So this is the most common thing usually we do for a complex injury in which we are not resecting it out. So diversion procedures have been like this. Pyloric occlusion has been in vogue for a long time. It has been there. It's in the textbooks, but things which are not being done nowadays. So this is basically opening up the anterior wall of the stomach in case of this kind of a complex duodenopancreatic injury, closing the pylorus with a proline suture and then closing this. So does it work? Does not? And we have to do a jejunostomy also, gastrojejunostomy also, obviously, along with this. Now, people worldwide have talked about pancreatic and duodenal injuries, and this is a Karim Brohi et al. From the UK. They said this back in 2005 that keep it simple. Try to do as little as possible, especially in unstable patients. Just temporary occlusion and reoperation. Later on, go and see and do a proper debridement and repair. Pylori occlusion data suggested that no, it's not required, does not help in the mortality, the no mortality benefits and all. So just keep it simple. Do not do a pyloric exclusion. That's the whole thing. Do a reconstruction or a triple tube drainage. That is good enough. Even people have vouched for this, that yes, should be abundant or not, and yes, things are not in discussion in present day literature. Keeping it short and simple, the take home points. It's a very vast topic. It's difficult, but the mechanism and the initial assessment will give us the clues whether there is any duodenal or pancreatic injuries. 1 and 2 grades of pancreas are managed non-operatively, and it may have some complications, but that also we can manage later on, like pseudocyst and all. Ductal restriction, however, is a major decision-changing finding. If the duct is gone, if it is a distal part, I mean only the left of the SMV, do a distal pancreatectomy. If it is on the right side of the SMV, try to save the pancreas, do a pancreaticojejunostomy if possible. You can also resect a major part of the pancreas in those situations if you cannot do that. In major duodenal injuries and in complex injuries, if the patient is very unstable, just put a tube, do triple decompression, a lot of drainage, and come out. Live to fight another day. But if the patient is a little bit of stable, it is better to do some kind of reconstruction, like a Roux-en-Y reconstruction, as we have discussed. When in a difficult situation, keep it simple. Don't worry, drain, pack, come out, live to fight another day. So that's it from me. Thank you.
Thank you, Dr. Niladri. That was very kind of you to have shortened your presentation also. Thank you very much. And I do thank the other presenters here, Dr. Joseph, Vignesh, Pratishka, Avinash, who helped us with the technicalities, Mr. Pinesh also, and to Professor V.K. Kapoor, sir. Thank you very much for allowing us to host this masterclass. Thank you all very much. Tomorrow there will be a session with 4 presenters. It will be on bowel injuries and pitfalls and pelvic trauma, as well as interventional radiology in abdominal trauma. Thank you all very much. And Professor V.K. Kapoor, sir, thank you again.
Thank you, ma'am.
Thank you, ma'am.
Thank you all.